All right, welcome back to session 2 here of the Imaging in the Emergency Department Cardiothoracic sections here. We have one more later this afternoon, but we have 4 good speakers that we're looking forward to this afternoon. And the first one is going to be Dr. Ferko Berger. He's out of the University of Toronto, where he's an associate professor. Looking forward to have his talk here on acute aortic syndromes.
Thank you, Ryan, for the introduction and also for inviting me to speak on the acute aortic syndrome, the topic of the talk, and you have it in your syllabus as well. That chapter was co-written with these co-authors who I'd like to thank for their contribution, both from the Emergency and Trauma Radiology Division and the Vascular Interventional divisions in our hospital, and none of us have anything to disclose. So the objectives of this talk are to describe the different entities that constitute the acute aortic syndrome, understand the classifications that's out there and some controversy with it, know the imaging protocol, selection and optimization thereof, and explain, of course, some of the key findings and complications of acute aortic syndrome. But I'll start you off with a few cases just to pique your interest and see what you would think. So this is a patient came in with the acute tearing pain that I will discuss, and we're just scrolling through it. See what you would like to mention in the report of a case like this. And we'll touch on the most important bits in my presentation. The second case is a chest radiograph, and the question is whether there's an acute aortic syndrome finding. The syndrome itself we cannot diagnose, of course. That's a clinical decision. And then the final case with the question is, this is a case of an intramural hematoma, and there's a bit of a contrast configuration in that hematoma. And is that something that you can leave, or is that something that needs specific attention? So I'll touch on that as well. These drawings that you can find on radiologyassistant.nl, which is from the Netherlands, where I'm from, are from a good friend who I like to credit with them. And these depict the 3 entities that constitute the acute aortic syndrome. The acute aortic dissection with an intimal flap, intramural hematoma, and penetrating atherosclerotic ulcer. I'll go into those. But why are they grouped into this syndrome? They are very similar in many ways. Their clinical presentation, their imaging approach, the classification used, and often, but not always, the treatment. So I like to think of this as a triplet that is a bit of unexpected in part. The clinical presentation, this is usually taking place in older patients unless there's disease of the aortic wall, usually in their 6th or 7th decade of life, and 2/3 are male, and there's invariably a long-standing history of hypertension. They present usually with a very severe tearing pain, and location may reflect where the tear is occurring. So a retrosternal pain could be in the ascending aorta, whereas the pain between the shoulder blades more typically is in the descending thoracic aorta. Sometimes they present with syncope or a pulse deficit, which is usually in the aortic dissection with the flap, or with complications resulting from hypoperfusion, so the malperfusion syndrome. Imaging, if this is a differential, is with CT. We like to start with an unenhanced CT of the chest. This will show the hyperdensity of the intramural hematoma. And that's especially important if it's a very thin layer. You will be tricked into not seeing it if you only give contrast. Then we perform an arterial phase of the chest, abdomen and pelvis so that you can see the extent of a dissection or the aortic pathology and assess the side branch patency. And then different institutions may do or not do this, but delayed phase to look at the actual organ perfusion can be part of the protocol as well.
Can we turn the lights down just a little bit to make it a little easier to see on the front screen there?
I don't know if that came through, but can we turn the lights down a bit, please? Yeah.
Thank you.
Thank you. You see two images here of a patient suspected of having an aortic dissection. The top image is an image that the patient received their contrast through the left arm. And you see the issue. I said it's important to track where that flap is going, and of course the branches to the neck are very important, but you cannot really very confidently make any decision on that potential extension if you give contrast through the left arm. On the bottom image, you see that the contrast given to the right arm has made it very densely into the SVC, but it's not obstructing the view of the branching vessels of the arch. So, if at all possible, for these patients, provide the intravenous contrast through the right arm. Now, in high-risk patients, I would do all the phases that I just described, except for if you have spectral imaging or dual energy imaging, you can leave the unenhanced CT and do it with a virtual non-contrast CT. If there's a low pretest probability, you can be more selective if you're worried about radiation dose, and I would suggest to actively monitor and be there. Maybe you can leave the delayed phase. Another question is whether you should do cardiac gating. If you get an image like this, you may be hesitant to say there is or there is not any dissection. However, this is a known pitfall, and the motion artifact is quite typical. And the non-gated technique, depending on your scanner, can be quite a bit less in radiation dose. Again, in younger patients and patients with a lesser probability, good to be radiation conscious and not do it. You can always still do it if you do have a question. If you do gate, as in the first session, it's good to aim for a heart rate less than 65 beats per minute, unless you have a high stable speed, a capable scanner. And here is an example of that. On the left, a patient that was scanned, and here is the ascending aorta, where you see these somewhat typical motion artifacts, but there was still a question, is there a dissection or not? One of the clues is the SVC is also suffering from the same motion artifact at the same region. If you do it on a scanner with a high table speed, you can see this is the same patient with the variant takeoff of the right subclavian. You can see there's no motion artifact whatsoever, and you can definitively say that this is not an aortic issue. So if you're capable of scanning at high table speeds, I would recommend that. One word on the chest radiograph. 25% of patients with an acute aortic syndrome have a normal radiograph, and it doesn't exclude anything that's happening in the lumen of the aorta. 75% do have an abnormal mediastinum, but often it doesn't confirm that that's an aortic issue. It may exclude differentials, but yeah, the CT is the method of choice in the acute setting. So let's go into more detail in the first of the three, the acute aortic dissection. So this is an entity where the intima is truly torn and blood from the lumen of the aorta dissects into the medial layer of the aorta, and it creates a false lumen. You can recognize this, and I'll show some examples, by the displaced intimal calcifications, and you often see a clear entry site. To distinguish an acute aortic dissection from an intramural hematoma, one of the things I pay attention to is the spiraling of the false lumen. If it is thrombosed or an early phase of scan where the false lumen hasn't opacified. Usually if it's a true dissection with a flap, the false lumen spirals around the true lumen, which it tends not to do in an intramural hematoma that tends to be location stable. Of course, when it comes to reporting, whether the ascending aorta is involved is paramount to report. To look for pericardial effusion or hematoma or mediastinal or pleural hemorrhage, those are key deciders for more aggressive management. Identifying the tear itself, both entry and exit, may have impact on management, and the true and false lumen supplies to different arteries. Be careful that sometimes the false lumen has not yet taken contrast, so it can resemble a thrombosed lumen. I mentioned the side branches and the organ enhancement already, and another thing to pay attention to is the aortic diameter. So the two best known classifications that are out there to classify this, if you want to be more synoptic in your opinion of your report, is the DeBakey classification, which really focuses on the site of the tear. So type 1 and type 2 are entry tears in the ascending aorta, where type 2 is more limited, only involving the false lumen at the ascending aorta. And type 3, the tear is in the descending aorta, and type is further subdivided with type B extending beyond the diaphragm. The more used radiological classification is a simplification, is a Stanford type A and type B, whereas type A has involvement of the ascending aorta and type B has involvement or lack of involvement of the ascending aorta. This is traditionally thought to make the difference between surgical and medical management of the patient, but there's a lot of gray zone. And there's one caveat to it as well, and that's the arch that was not really shown in that image, but can be either the primary entry site or involved. So that is not very clearly defined, and there's some debate in the surgical versus radiological literature about these classifications. Some authors have now added the non-A, non-B type dissection. For management, probably the most important thing is whether the ascending aorta is involved and whether the side branches are involved going to the neck. Couple words on the distinction between those lumina that I showed. Oftentimes the true lumen is the smaller one. It's of course contiguous with the normal aorta true lumen. It usually hugs the lesser curvature of the aorta, and in the arterial phase the density is usually higher than the false lumen. In the false lumen, you can have a beak sign, which means that the false lumen has an acute angle wrapping around the true lumen, or remnants of the media that are, which is called a cobweb sign. The true lumen usually, but definitely not invariably, supplies the celiac trunk, SMA, and the right renal artery. So I'll show these in an example. So we already passed the entry site, which is distal to the takeoff of the left subclavian artery. So this is a type B. The false lumen is bigger than the true lumen. The true lumen has circumferential calcifications, whereas the outer wall of the false lumen will not have these intimal calcifications. And then here you see the spiraling of the false lumen around the true lumen, which is a nice sign to take into account on a stack. Here in still, again, the same cobwebs in the false lumen, the beak sign that I was talking about, and the differential opacification of the false lumen. In a type A dissection, you often have this centralized true lumen. Here you can see the entry site. So complications of acute aortic dissection are rupture, usually of the false lumen with an irregular outer wall, and you can see extravasation of contrast, which of course makes it a very high emergent situation, and hyperdense pleural effusion or hemothorax. Extension of the dissection can be either retrograde or antegrade as a complication. And if there is aneurysm formation, so enlargement of the aorta, in about a third of the cases, it will lead to a rupture and late death. Specific to type A, you can have pericardial rupture and cardiac tamponade. There can be extension into the origins and quite distally of the neck arteries, giving potential rise to neurologic complications, and aortic valve regurgitation as well. In both type A and type B, you can suffer from the malperfusion syndrome, again, with blockage of the branching arteries, and that is a strong predictor of poor outcome. And then there's such a thing as static versus dynamic obstruction, or a combination of the two, which I will show after showing a case of the complication. This is the unenhanced CT, and you can see the hyperdensity from the acute hematoma. This was a patient with a longer standing known dissection, type B dissection, which often are monitored. I don't have many of these cases, but this is to show that the rupture doesn't necessarily need to come from the false lumen. This is actually a rupture of a true lumen, as you can see here. More usually it will be the false lumen though. So going back to that concept of static and dynamic flaps or obstruction, in a static obstruction, the true lumen usually keeps the rounded appearance, and the obstruction can be caused by thrombus that is occurring in the false lumen, blocking off some flow that may go to the organ through the false lumen. Dynamic obstruction will actually vary with the cycle, the cardiac cycle. So in diastole, it may have a bit more a different form than in systole, and then you have the combined phases. If you see a collapsed true lumen like this, that's a ischemic configuration, as we say. Here's an example. So this is a type A dissection where the true lumen is actually completely collapsed. It is extending into the branches. And this is sort of a spaghetti-like true lumen, completely surrounded by the false lumen. And then, I don't know if that comes across very well, but the ascending aorta is enlarged, and that flap is a dynamic flap that is sort of obstructing everything, but it's quite a bit more unusual in my experience, at least. I don't know if people have seen this many times, but here you can see that the wall, the intima-medial flap, has actually prolapsed through the aortic valve back into the heart chambers. And this is an example of the dynamic obstruction. So report the extent of the flap and which arteries are involved. Here's another case where that type A dissection is obstructing the coronary, so you can get acute myocardial ischemia from it. And the end organ perfusion. This is an example where the flap goes into the renal artery with a renal infarct. So let's move on to intramural hematoma. It's about 10 to 20% of the acute aortic syndromes, usually tend to be a bit older than the dissection. Long-standing hypertension, again, sometimes it's an incidental finding with the patients not really having symptoms. It's thought to be caused by a rupture of the feeding vessels of the media of the aorta, although that is disputed by others who say it may just be a tear that you don't see with a clotted medial layer. On the unenhanced CT, this will be a smooth crescentic or circumferential hyperdense thickening of the wall. There's usually no lumen narrowing of the aorta, and as I said, it doesn't spiral. The internal displacement of the intimal calcification does occur, and it's most frequent in the ascending and proximal descending thoracic aorta. Again, there's no enhancement, but be careful if you only do CTA, you may miss the smaller ones. Typically, there's no branch occlusion. Here's an example where you can see the hyperdensity and the displaced intimal calcifications, and if you give contrast, it's of course much more clear. This is another example of the sort of static position of that hematoma. And this was a case where the right kidney was obstructed. Complications specific to intramural hematoma. There's progression to a frank dissection in about up to 50%, rupture in about 20 to 45%. Ulceration does happen with formation of sacral aneurysms, and a late complication often is a fusiform aneurysm. Predictors of these complications are when the ascending aorta is involved and the diameter of the aorta exceeds 5 centimeter, or the thickness of the intramural hematoma exceeds 2 centimeter or is increasing on sequential CTs. Of course, pericardial or pleural hemorrhage is a poor sign too. In a normal diameter aorta, IMH usually actually resolves. So here again, an unenhanced CT, narrow your window to make the hematoma stand out. And here are a couple of those measurements. So if the total diameter is more than 5 centimeter or the IMH is more than 2 centimeter, there's a higher risk of complications. One thing to mention that's taking back to that case that I showed is the difference of these contrast configurations in the intramural hematoma. If there is a small neck and there's a branching artery, it's usually an intramural blood pool, and these are stable or they will resolve, whereas a broad neck protrusion of contrast into the IMH usually does not. Also like projection. So here's a case that had them both. This is the initial scan with the intramural hematoma. There is a little bit of contrast in the proximal descending and a more broader necked protrusion of contrast in the descending. And you can see that it stays stable or even resolves mostly on the first and progresses on the latter one. This is a case of intramural hematoma as well, and these can be quite subtle. This irregularity here is also like projection, and it does change management. This patient got a stent for that also like projection, and then developed these more sort of focal dissections at both sides and start and the end of the stent. The last one is PAU. That's an ulceration of a soft plaque in extensive atherosclerotic disease, and it penetrates the intima and causes a focal hematoma in the media. It's usually more distal, although here I'm showing an example that has both proximal and distal examples, but the key sign is the extensive atherosclerosis throughout the aorta. If there's no pain, don't call it PAU. It's only part of the acute aortic syndrome if it is an acute setting. The prognosis is poor if the diameter is more than 20 millimeters and the depth more than a centimeter. And they have high risk of progression, and this is what you can see. You can have these sacral aneurysms in a more chronic phase, or patients can lead to rupture. So management has evolved over the last decades. It's less aggressive unless the ascending aorta is involved. Stents now also can cover the branches. In the acute stage, it's often blood pressure control, unless you have signs that really need emergent management. So ascending aorta involved, hemopericardium or tamponade, certain side branches involved, and you can see some examples of those here. One complication that is maybe a bit lesser known is that the intramural pathology can extend to the pulmonary artery, and that's a low pressure system. So you get this sort of narrowing and even occlusion of the pulmonary artery through the extension of the mural pathology to the sheath of the pulmonary artery. So that brings me back to the cases. This was the first case that I showed, a type A dissection going into the branches, displaced intima calcifications, a big entry tear at the ascending aorta. But maybe what you may not have seen is that the pulmonary artery system is a bit narrowed as well. There's extension to the sheath, and of course the hemopericardium had already made this a very urgent one. This case that I showed illustrates the fact that you cannot rely on the radiographs because this was a type A dissection as well with right renal infarct. So what I would like you to take to work is that acute aortic syndrome can be a life-threatening condition with a spectrum of same diseases, always in long-standing hypertension and with atherosclerosis. Don't trust your chest radiograph and choose your CT protocols wisely with contrast via the right arm. And then if you like more emergency radiology, I'll plug in ACER later in the year. Thanks for your attention.